So the last thing we want to talk about here is culture. Culture plays a huge part in how we communicate with people. So I want you to take some time to think about your own culture. What is it that you believe about, female, male roles? What do you believe about aging? What do you believe about time even? That's something we don't really consider, but there are a lot of cultural differences when it comes to what we think about time. Caucasian cultures, most of them are kind of future oriented. What am I doing tomorrow? What am I doing in 10 years? Where am I going to school? Where am I going to college? Where some other cultures, like African American cultures or Hispanic cultures, they're about the present, living in the moment. What's happening right now is what's important. Of course, these are all generalizations, but we want to be aware of those things when we're communicating with our patients and our residents that, they might come from a different culture than us, and they might not have the same types of beliefs that we do, and that's okay, but we need to understand what those beliefs are so that we don't have miscommunication. So when you have somebody who's from a different culture than you, as a patient or a resident, try to learn as much as you can about that culture. What's considered respectful or disrespectful, especially. For example, eye contact. In some cultures that's considered respectful. In most American cultures, making eye contact is considered respectful. But in other cultures, making eye contact is considered disrespectful. You should cast your eyes down when you're speaking to someone that has authority over you, for example. So learn about those cultures, and cultural awareness is something that's going to keep coming up over and over again throughout nursing school. So learn as much as you can about those other cultures. All right, so next we can talk about aphasia. All right, so when we think about aphasia, the first thing that comes to mind is somebody who's had a stroke. You're all going to be taking care of someone who's had a stroke when you go to clinical, because it is so common. It's the number one cause of disability in the U.S. So a lot of people who've had strokes wind up in long-term care. And this is one of the things that can happen when somebody's had a stroke. All right, it damages part of the brain that deals with communication. So I have 3 different terms on here. Broca's aphasia, that is a type of aphasia that deals with expression. It's called expressive aphasia sometimes. So you might be trying to say something and that word is just right on the tip of your tongue and you can't find it. So you've all had that feeling before, and you know how frustrating that can be. Right? If you're trying to think of somebody's name and it's just right there and I just can't grab it, I can't say it, that's frustrating. So that's a type of aphasia. Wernicke's aphasia is receptive aphasia. So you might be speaking, but it sounds like gobbledygook to me. I don't know what you're saying. It might as well be a foreign language. I don't know what you're saying. All right? Global aphasia is a combination of the two. So this is frustrating. So it's very important when you have somebody who has aphasia to speak slowly and carefully and clearly. All right? And maybe if they're not understanding what you're saying, think of another way to say it. Using your hands, being expressive. So if you've ever played charades, it's kind of like playing charades. Okay? So you brush your teeth, you go for a walk, are you having pain anywhere? Are you tired? Think. Okay? Think outside the box a little bit. Sometimes we just have to think when we're doing this, when we're communicating with somebody. All right, the thing about this is we should not treat the person as if they are less intelligent, because sometimes they're just trapped inside their mind. They haven't lost any intelligence, they've just lost the ability to express themselves. Right, so think about how you would feel. That's being empathetic, right? Putting yourself in someone's place. How would I feel if that was me? Okay, so patience is a virtue here again. Right, so documentation. This is a big portion of this chapter. Documenting the correct way. So let's talk about the electronic health record. That is how you're going to be documenting almost everywhere that you go now. And the only reason that you wouldn't document in a health An electronic health record is if the system were to go down for some reason, you have to document on paper, which I'll teach you how to do that. But just know that everything is tracked now on an electronic health record, and that way we can pull it up, we can store it for long periods of time. It doesn't take up any space, it's easy to send, and it's easy to track. So everything you put into an electronic health record gets a stamp on it, and it's saved forever. You can't go back and erase anything. I mean, you can, but that record's always going to be there. You know, it also tracks who gets into a chart. So if you're looking at patients that maybe you have no business looking at, it's going to track that. So you want to be mindful of that. So these other components are going to be on this electronic health record, right? Most of the time, it's going to be in there. It might be called something else, but the same principles apply. So Cardex is kind of like a quick snapshot of our patient or our resident. Tells us what their diagnosis is. It tells us some of their orders. You know, it gives us a little bit of demographic information. So it's just a quick snapshot of that patient or that resident. Flow sheets are the things that we're going to be documenting things on, stuff like vital signs, intake and output, anything that we're tracking that could be graphed, that's going to be on a flow sheet. MDS is for long-term care, all right? It's a minimum data set, that's what it stands for. It's required by OBRA, and it is the minimum amount of information that you need to collect about that person that you're taking care of. So, for example, their transfer status, how did they get up? Did they need 1 assistance, 2 assistants? Were they independent? How did they use the toilet? So that stuff needs to be documented daily. When you guys do go to clinical, you're going to see the CNAs documenting that minimum data set. So make sure if you can't get into the electronic health record yourself as a student, watch them when they document so you can understand what that is. All right, so there are some legal aspects to documentation. First of all, if you are documenting on paper, you have to write in pen. So I hope that you can understand why that's important. If you write in pencil, it can be erased, right? We don't want that to happen. It needs to be in pen. And most facilities have a requirement of blue or black ink, so you need to know that. Always sign with your full name and your credentials. All right, so when you guys go to start documenting things, that's one of the skills that you need to be signed off on. You need to sign your full name, and then you need to start putting your credentials afterwards. So you might say, I don't have any credentials yet. So when you guys go to clinical, if you do write a note, you're going to write your name. So I would write Jenny Taylor, SNA, Student Nursing Assistant, comma, DTCC. They need to know who you are, what your credentials are, and where you came from. All right, so practice writing that signature, SNA, comma, DTCC. Okay. If you happen to be writing a note about an incident that happened, you need to avoid using your opinion as much as possible. All right, so I wouldn't want to say, for example, patient is angry. All right, because that's my opinion. And if this were to ever go to court, God forbid, I need to be able to defend what I wrote. Okay, so I would write, patient frowning, pacing the room, stated, F you. That's a little bit more of a clear picture than patient is angry. Okay, and it is perfectly fine to put what that person said in quotations. I do that all the time. So if somebody cusses me out, I'll put a cuss word right on that note, okay, because now it's clear to everybody how upset this person was. Those are things that we need to know. So refrain from using your opinion as much as possible. Put in as much subjective and objective data as you can. So subjective data would be something that you cannot see, okay? So if somebody tells you they feel nauseous or, nauseated, I can't see that. I'm going to write a note about it. And I'm going to use their exact words, okay? Pain, dizziness. Those are things that we can't calculate. We just have to go by what they're telling us. Objective data would be something that I can see. So vital signs, a rash, bruising, things like that. Throw both of those in there. Never put any blank spaces in your notes, right? Because somebody could come right in there afterwards. Gather as much information as possible, all right? So if somebody tells me I'm having pain, that's not a good no. I need to know where her pain is. How bad is it on a scale of 1 to 10? What does it feel like? Is it stabbing? Is it throbbing? Is anything making it better or worse? And you're going to learn more about this stuff later in nursing school. But even now, you know, if you're taking care of somebody and they tell you something and you need to go tell the nurse about it, get as much information as you can before you go and tell the nurse about it. Another important thing, you should only chart something after you've completed it. You should not, I'll give you an example. I worked with a CNA who charted for her whole shift because she didn't feel like charting that night, I guess, but then her patient died in the middle of the night. So for her whole shift, she documented that person was sleeping, but then they died in the middle of the night. So that didn't look too good on her, right? You should only document something after it happened. Never document something that someone else did unless you witnessed it. All right, so if somebody's left for the day and they call you up, hey, I forgot to document this blood pressure, can you do it for me? Sure can't. Nope, because I didn't take it. I don't know that that's true. Don't document anything for anybody. Everything you document becomes a legal document that could go to court. All right, so if you can't defend it, don't document it. And if you didn't do it, don't document it. Lastly, this is important, we use military time in healthcare, all right? So you want to look at the time and convert it to military time. We don't use AM or PM, okay? So if you don't know how to use military time and you start practicing it, you can set your phone to military time so you get used to seeing it all the time. So right now it is 4:05 p.m. while I'm recording this, so that would be 16:05. All right, and make sure that you use exact time. Don't round by fives, which is something for some reason that we like to do. All right, so right now it's 16:06. Okay, so if something happened right now, I would document 16:06. All right, so just, you know, practice writing some notes the correct way. And this is something that you're going to carry with you throughout nursing. Some very basic principles here. If you do not have any knowledge of medical terminology, you want to start looking into that. Okay, the back of your book has an index with a lot of medical terms that are very common. So start looking at those and familiarizing yourself with those. All right, so this is the nursing process. When you guys get into nursing school, you'll be going through this over and over again. This is very different than medical process, okay? So the first step in the nursing process is to assess our patient. All right, so if I get a new admission, I'm going to assess that person. My next step is to diagnose. And this is not a diagnosis like Parkinson's disease. This would be a diagnosis like risk for falls. A nursing diagnosis, okay? So I've assessed my patient. They look like they're at risk for falls. That's my nursing diagnosis. So now I need to come up with a plan. How am I going to keep this person from falling? Well, I can get non-skid socks for them. I can make sure their bed is locked. I can ask them to call for help when needed. Those are all steps that I can take that are related to that nursing diagnosis. Okay, that's my plan. And then I'm going to implement that plan. So I'm going to let my CNAs know that's working with me. Hey, listen, you need to get this guy some non-skid socks. Make sure you know that he calls. That's implementation. And then I evaluate, was that successful? Did I do enough? And then I start over again, assess them again. Okay, it just goes round and around and around. Okay, last but not least is Maslow's hierarchy of needs. So if you're not familiar with this, get used to it because you're going to see it over and over again. So review this. And this is in your book, so I want you guys to review this, okay? So physiological needs like food and water, safety, then love and belonging, then esteem, and then self-actualization. So lastly, review your vocabulary words too. They're on that note template. And if you have any questions, bring them to class. And thank you. I'll see you later.